Hi everyone, it's me, Sandy Cruz of Sandy K Nutrition, Health and Lifestyle Queen. For years now, I've been bringing to you conversations about wellness from incredible guests from all over the world. Discover a fresh take on healthy living for midlife and beyond, one that embraces balance and reason, without letting only science dictate every aspect of our wellness. Join me and my guests as we explore ways that we can age gracefully with in-depth conversations about the thyroid, about hormones, and other alternative wellness options for you and your family. True wellness nurtures a healthy body, mind, spirit, and soul. And we cover all of these essential aspects to help you live a balanced, joyful life. Be sure to follow my show, rate it, review it, and share it. Always remember, my friends, balanced living works. Hi, everyone. Welcome to Sandy K Nutrition, Health and Lifestyle Queen. My guest today is Dr. Bruce Dorr. He is certified by the American Board of Obstetrics and Gynecology in OBGYN and female pelvic medicine and reconstructive surgery. He's a member of the American Urogynecology Society and the American Association of Gynecological Laparoscopics. Whoa, that's a mouthful. He became certified as thank you. He became certified as a Bio-T medical practitioner in 2015 and provides hormone optimization with pellet therapy for both men and women. He has treated female patients referred to cardiologists for irregular heartbeats, endocrinologists for weight gain, and even marriage counselors for vaginal dryness and loss of libido. Effective treatments for these patients were not initially prescribed because changes in hormone levels were not identified as the root cause for their issues. So today, we're going to talk all about menopause. We're going to even talk a little bit about some of the topical stuff that's coming out now, and the New York Times article that came out recently about women being misled about menopause. It's huge news. And who better to speak to or speak with about this than Dr. Bruce Dorr? So with that, welcome.
You can speak to me too.
Okay.
I think that's awesome. Huh?
I like speaking with you. How about that?
Okay,
it sounds better. It sounds better. So I am just so excited for this conversation because that article is almost like it was a springboard for our meeting.
Yes.
Yeah.
And very much needed. It was just a welcome across all fronts when we hear about menopause. And even, you may have seen it too, the Super Bowl, they even had a featured segment on vasomotor symptoms or symptoms of menopause that was in a 30-second commercial also. So women and their needs are definitely getting out there, which is very much a blessing.
Okay, well, my team was not in the Super Bowl.
Oh.
So, I'm a Buffalo Bills fan over here. So
I think we were all hoping for the Buffalo Bills, but yeah, it didn't happen.
So I did miss that.
It kind of became America's team for a minute.
Yeah, I did miss the segment, but I have to ask you, what got you into this field that you're in right now?
Well, actually, I went into medical school to become a psychiatrist. But as I got further into the field, I just found I was so drawn to the field of OBGYN because the medicine involved, the procedures that were involved, and the charm of the whole labor and delivery experience was just overwhelming to me. And to me, it was kind of what life was all about. And just felt that. And as I got into it, yes, I started to subspecialize in urogynecology and, all the stuff. It's kind of an evergreen area as far as OBGYN goes. We're either helping women get pregnant, helping them through their pregnancy, or helping them with all the stuff that happens after their babies.
Yeah.
And so it is really a blessing to be in the specialty. And, I really didn't realize how lucky I was seeing women virtually my whole career until I started seeing men. They're a tougher crowd.
Oh, yeah.
And so I think, women are just, they're unfortunately no stranger to medicine and therapies. And I think in general, much more open to my advice. And that's been the beauty of my career. Interestingly, the whole menopause emphasis, I would see women with unfortunately very painful conditions, one called endometriosis, and we would need to remove their ovaries sometimes at a very young age. Even as young as I had one lady so severe, she was 16 years old, that I had to perform, and remove her ovaries. And I would see women that I would put into surgical menopause, and although their pain was gone, they went to this very dark area. And I had one patient specifically, she was 38, and her pain was gone, but she no longer wanted to have sex. She no longer wanted to work out. She was gaining weight. And she just said to me, I just wish I wish I was in pain again and had my hormones back. And she started taking her husband's testosterone preparation, and I saw her as kind of a crazy level, 700. It's very high for a woman. I referred her to an endocrinologist, and the endocrinologist said, well, why would you do such a dangerous thing, taking your husband's testosterone? And she said, well, I just felt better. I had better energy. I had better libido. I felt like I did before my surgery. And he says, well, I just don't understand. You're 38 years old. And she said, yes. He goes, well, how much longer do you think you're going to be having sex?
Oh, wow.
I know. So this is what is happening when people see, experts in hormones, that I would see my patients being treated like that. And that's how I got introduced to BioT and to learn more, to really be full service for my patients that need hormones at any age and their husbands.
Yeah. I mean, that unfortunately, I've heard all too many stories similar to that. And it's really unfortunate. But then there are physicians out there, and I always say that there's physicians out there that will work alongside you and help you to feel optimized, because life's too short. Life's too short to go through it feeling like you're going through it with no vitality. It's just unfortunate. So talk to us about, because there's always confusion. Like, what is menopause? Let's start with the very basics.
Right. Well, menopause, defined by the American College of OBGYNs, is the cessation of your periods for a year, usually combined with menopausal symptoms. And what's going on physiologically is that the ovaries stop making estrogen. And there's a time leading up to that total stop of estrogen is what's called perimenopause. And that's where, some days pretty good estrogen production, some days not so good, some weeks pretty good, some not so good. And it's that roller coaster that can start, a few years before, on average, a couple years before the periods totally stop. But some people start that as early as their late 30s or mid 40s. And so that up and down will cause irregular bleeding, which is a majority of the consults for women in their 40s seeing an OBGYN as irregular bleeding. And yes, many will address the bleeding, but they don't address the women's symptoms that are going on surrounding that. So with that hormone loss, then comes all the stuff that can either hurt us or kill us. So acceleration in risk for dementia, accelerations for risk of bone loss, for heart disease, for breast cancer. That all happens with that loss of estrogen.
Yeah, I mean, I guess it's a good time to talk about some of the symptoms because, you and I both read that article, Women Have Been Misled About Menopause.
Yeah.
And I think there are a lot of pros and cons to it. And I'm not a physician, but I know a lot about menopause, and I happen to be 53 years old. And I'm kind of getting through it pretty good. I'm
Yeah.
feeling good, and I'm feeling that I don't feel like I have a loss of vitality. I don't feel like I want to kill my husband every day. So, I mean, there you go.
Right.
These are all bonuses, right?
Well, looking at you, Sandy, everybody's going to want to know your secret because you look like you're about 20 years old.
And I'm not using a filter. I swear to God, no filter.
Oh, okay, good.
No filter. But you could see I get flushing. So there you go. There's a symptom right there.
Well, people accuse me of not using filters either, so that's just a problem I have, but different story altogether.
So, this article, they like the one thing from this article that really stuck in my mind, and I would love for you to talk more to this, is the brain lesions and the correlation to hot flashes.
Yep.
And the intensity, severity, frequency. That was like, I have to say, I knew a lot of what the science has been saying, but that one was huge. It just struck me like, oh, wow.
Well, they're trying to put their finger on is what causes the hot flushes, what causes these vasomotor symptoms. And they're kind of coming down to, and it's also coming down to what is the problem for some women that have irregular periods, a condition called polycystic ovarian syndrome.
Okay.
And that leads to irregular production of estrogen and progesterone balance that goes on that can sometimes happen in that perimenopausal time period, but that is what happens with a signal that comes from an area in our brain called the hypothalamus. And that is what pushes a signal to our pituitary glands that then push the hormones to either our testicles or the ovaries, is the thing that way too. So what they're getting at in that article is that that area in the brain is having dysfunction. And so these levels that then happen at the pituitary level are associated with night sweats, hot flushes, and those kind of things going on. And it's being brought to light because of a new drug that's coming out on the market. It's called an NK3 receptor antagonist. And it basically is helping with a neurokinin. It's a brain chemical messenger that sends these messages to the pituitary that then activate the ovaries. And so they're finding that problems in that area of the brain is probably what's the bigger cause of vasomotor symptoms specifically. But we know that these lesions, especially related to Alzheimer's disease, it's a protein called beta amyloid. And there's also another one associated called the tau protein. And it's the accumulation or the presence of these that is kind of the diagnosis of Alzheimer's disease.
Is that the plaque?
Yes, those are the plaques that go on, and they entangle the nerve fibers and these pathways that allow us to process things in our brains. And the things that help decrease beta amyloid deposition are sex hormones. So both estrogen and testosterone are known to decrease beta amyloid deposition. Now, in her article, she's saying that beta amyloid deposition is starting in women in the perimenopause. But, I've talked to Alzheimer's researchers, and they've even seen beta amyloid deposits in fetuses.
Wow.
So, and we see that much more in the mid-30s or so when women start to lose their testosterone. And so that's also a problem. Low testosterone in both men and women is also associated with increase in plaques and brain and cognitive impairment.
Okay, so does this mean, it just, if somebody's just reading the article who's not a physician like yourself or listening to the podcast, they're going to be like, oh my God, I have tons of hot flashes and I have them all the time and I have them every day and I have many and many and oh my God, I'm going to have dementia. I'm going to have Alzheimer's by the time I'm 60. So like, people, it can cause a little bit of panic.
Oh yeah. Well, and panic and inflammatory statements sell. When you look at benefits and health and doing the right things for our bodies and diet and exercise, that doesn't sell as much as, a balloon over the Atlantic or, anything that is inflammatory or reactionary is the deal. So I think the key is that if you're having symptoms, it's good to talk to somebody that these symptoms can be associated with problems long term. And it's not necessarily just vasomotor symptoms. When you look at a reanalysis, and I know we'll probably talk about it, of the WHI that every woman went off their hormones, or majority of women went off their hormones. Yeah. When you look at a reanalysis, it's actually not necessarily just hot flushes or night sweats that caused long-term increase in cardiovascular disease or all-cause mortality. The biggest symptom that was associated with all-cause mortality was dizziness. Oh. So, it's not just about night sweats or hot flushes. There's like 40, some people say there's as many as 100 different symptoms related to menopause, but there are much more significant symptoms that can be associated with things that can kill you, not just Alzheimer's disease.
Okay, so let's talk about the major ones then, Dr. Dorr. Let's talk about the major ones. We talked about hot flashes. What other ones should we really pay attention to?
Yes. Well, and that was kind of your intro, to me, is that as a urogynecologist, I work with a lot of certainly female pelvic disorders and incontinence. And so I would see women for their incontinence, but they had been to the endocrinologist, they had been to a cardiologist, they had been to a rheumatologist, because really the number one symptom of menopause is joint pain. And so, women stopped exercising. They stopped walking the dog. And so that's really the number one symptom over night sweats. And people just attribute that to getting older. But really, it's the loss of the joints and the synovial fluid and the ligaments and the muscle loss that go on with the loss of hormones. But it can be irritability. It can be palpitations. It can be vaginal dryness. It can be many different things that people think, oh, yeah, maybe it's my diet or maybe it's, something else. And nobody's wanting to talk about menopause. It's easier to talk to somebody about your heart racing than it is your vaginal dryness or those kind of things going on. And so, the cardiologists don't want to deal with hormones, and so that's what it comes down to is, what is that root cause rather than the bandage on, putting somebody on something that slows their heart rate down or putting them on Motrin or aspirin to cover their joint pain. Get to that root cause as far as what's really doing that. It's the functional medicine piece of this.
Yes. And, it's so interesting because that happens in other parts of medicine too. And I have no thyroid, right? So I know a lot about thyroid. I studied it and I live it. And I think experiencing it, but seeing a client from a nutritional perspective who comes back and says that their physician put them on anti-anxiety meds and then seeing that they're severely hyperthyroid, you know what I mean? It's kind of like that same idea of not looking at what's the root cause. And, the fact of the matter is it's going to happen. Our hormones are going to decline, right? Like we kind of like, I can't be 30 forever. Right. So that's one fact that we have to face. So I love that you mentioned lifestyle, because that was the other big piece that was not really talked about much in that article. And I was like, okay, there's a lot missing here, because there's a lot we can do other than, taking the medications, right?
Right. So when you look at diet and lifestyle, when you look at other areas of the world, like say, look at Japan. their incidence of menopausal symptoms is significantly less than the average Canadian or American. And it's because of their diet, their diets that are rich in omega-3 fatty acids. So there are things in the precursors for our hormones and things that help our bodies and our brains nutrition-wise that help us feel better, to help with diet and exercise and things like that go on, that can certainly mitigate the severity of our hormone loss. So yes, that is another key component. But the problem is, they did a recent survey that 60% of OBGYNs, when women come in with menopausal complaints, prescribe an SSRI. They prescribe, an antidepressant because that's easy. And that can be handled in 5 or 10 minutes. Oh, you're having this. Let's put you on this drug. I'll see you in 3 months. But to sit down and talk to somebody about, what are you eating? How often are you exercising? Are you experiencing sexual dysfunction or disorders or things like that? Most people do not want to spend, really you need a good half hour to 45 minutes to talk to somebody about their life and their lifestyle, and it's much easier to put them on a drug. And many people, that's kind of what they want. They want a quick fix.
Yeah. I think we need to, as a society, get away from this whole quick fix, because just like what you do, hormones, it's this beautiful symphony, right? And so you got to kind of play around with it. Like I myself, I've been on bioidentical progesterone for years now, because that is what's helped with my sleep. I have no issues with anxiety. I have no issues with, being overly hyper and nervous, because I rhythmically take bioidentical progesterone. So maybe talk to us about that symphony of hormones.
Well, just like you're hinting at, women will start to lose their progesterone production in their mid-30s. And that's when PMS starts to come into play. That's when we can start to see pregnancy loss, because progesterone is the major hormone of pregnancy. So we look at that when somebody's pregnant, but we don't necessarily equate that to negative symptoms that start happening in the mid-30s, and then get even worse as they approach menopause and start losing that even more so. So I have many women that I'll put on cyclic progesterone, just like you're taking. You have to go low, because everybody's different as far as what their right progesterone level is, what their right testosterone level is, what their right estrogen level is. And there are many people, and I can see this as I do blood tests, that there are some women that their brain will tell me it's their right estrogen dose with a level of 30. And for some women, it shuts off, or the signal is good at a level of 120.
Wow.
So that's why when you do a standard preparation available in my cupboard, with a patch, a gel, a pill, a spray, is way too much for some people and way too little for others. So to have variability in dosing, it's a very individual thing for every patient as far as how much they need that can take them to too much or too little. So it's finding that mama bear porridge on each individual patient. And most people, don't want to take the time to work with patients. Like you may know with thyroid, there's a broad range of where people sit in thyroid.
Oh, yeah.
And many people will say, your thyroid is normal. Well, what is normal? Is that an A student or is that a D student? So same thing goes for hormones. Hormones and, say, thyroid are things that we can control. I can't control my kids. I can't control North Korea. I can't control whatever, is the deal that way too. But I can control what goes into my body or my patient's bodies, whether or not that's food or nutrition or these hormones. And so the things I can control, I want to be an A student in those. And that's where I try to take my patients, is to that best level that we can control.
I love that you say that, because, there's a difference between being in the range and being optimized.
Right. So we do the same thing, whether or not that is with testosterone or estrogen. Progesterone tends to be a little bit less that way too, but certainly I do the same thing with my thyroid patients.
Okay, so let's okay, we know progesterone is more that hormone that kind of makes us more chill. It helps us to sleep. It will help with anxiety. Did I miss anything with
Well, it
progesterone?
has, a number of different functions. And, when you look at estrogen or testosterone, there's over 400 different receptors for these hormones in our body. And they activate those processes, whether or not it's your hair, your joints, your skin, your nails, your fat, these are activators all over your body. So it manifests itself in different ways depending on, what we're doing and how our bodies are structured, both genetically and chemically.
Mm-hmm. And I guess,
So
sorry, go ahead.
go ahead.
Go ahead.
Oh, well, in general, so, it helps some people more with their brains. It helps some people more with their joints. It helps some people more with their muscles or libido or things like that. So it's a combination of figuring out, what people need, on that hormonal scale.
And do you take, I'm sure you do, but I guess you would take into account blood work on top of lifestyle, on top of symptoms?
Yes. Yeah.
And would you say that the majority of women that come in to see you that are, say, my age, 53, they say that they have joint pain, would that automatically kind of set off a bell that, okay, estrogen, that's probably related to estrogen or
testosterone? When you look at Dr. Rebecca Glazer, she is a breast cancer surgeon out of Wright State University in Ohio. She did a 10-year study looking at testosterone replacement only in women, and these were both premenopausal as well as menopausal women. And she had relief, almost 90% in all of her menopausal patients just on testosterone alone.
wow.
So it's not always just estrogen, it's the combination of estrogen and testosterone. But testosterone has this kind of juicing negative connotation that people are scared of it. They think of it as a male hormone. But women make 3 to 4 times more testosterone on a daily basis over estrogen. And so you can go far. It's the balance of all these things. And so for years, I would treat people with standard hormone replacement. I'm kind of a good old boy. I was there before, all the hormones kind of stopped in 2002 is the deal that way too. But, I would put people on estradiol and they'd still have all their symptoms. They still have night sweats and hot flushes and all their menopausal symptoms. And it wasn't until I started doing testosterone replacement with my patients, they're like, this is how I used to feel. That was the missing piece for some, if not many, of my patients. So it's the balance of both estrogen, testosterone, and progesterone that many people don't even recognize testosterone replacement in women.
Okay. And so it's not like myself as a woman who's 53 really, I guess I might be concerned about getting those chin hairs and or acne from taking testosterone. Like we have to also be careful, and work with a physician that knows what they're doing.
Yeah, with any hormone, you need to do that. And so do I return people to that puberty stage? Yeah, to some degree, you can do that. There's a dual-edged sword to testosterone. And you can make women into very manly-looking women with the amount of testosterone. So the difference between a medicine and a poison is the dose. So it's about finding that right testosterone level. So women lose half of their testosterone by age 40. And so you'll see women who kind of crash after delivery and they're like, I have no libido. I have no energy. I'm not sleeping anymore. And they're still having regular cycles. They're only 38 or 40, but I draw their testosterones and it will be 0.
Oh, wow.
And some labs will say a normal testosterone in a woman is 0 to 35, but it's not normal at all. But people go off of lab reference ranges rather than really what is making the difference individually for these patients. So I see menopausal symptoms in women in their 20s, and it's not the loss of estrogen, it's the loss of testosterone.
Oh, so interesting. Because I know a lot of women, they're just afraid of that. But I know, I'm familiar with Dutch tests and a few other functional tests. And we all have testosterone, people.
Exactly.
It's important.
Right.
Okay, so let's maybe talk a little bit about, we have to mention some of the flawed studies that did such a huge disservice to so many women
Right.
and
Right.
scared the pants off them, right?
Right. Right. So yeah, there were observational studies in the 90s, and they looked at women on hormone replacement and long term. Yeah, in general, they had better hearts and they functioned better. And so they said, well, let's really put the pen to the paper and see. And it started with the HERS trial, which is the hormonal estrogen replacement study in the late 90s. And it showed that there was statistically no improvement in cardiac outcomes on women when you put horse urine estrogen into their bodies. And that became even more so, and the makers of Premarin, so the number one prescribed hormone and the number one best studied hormone ever, pregnant mare's urine, 30 different horse urine estrogens, none of them were meant to be inside women, when they then were studying that because they wanted to get an FDA approval to prevent heart disease. So they were going for gold, that they would then be, prescribed by everybody. And unfortunately, when they looked initially at women that went on horse urine estrogen and a birth control pill type of progestin. So when you take estrogen, it can increase proliferation of the inner lining of the uterus or cause bleeding. So you have to take estrogen's counter hormone with it, progesterone. Progesterone is what's naturally meant to be in women's bodies, but they were using a chemically made medroxyprogesterone acetate that absorbs better and is cheaper. And so that's what they combined it with. And women that were taking the unnatural estrogens and the unnatural progesterone had an increased risk of heart attack, stroke, and breast cancer, and they stopped the study early. They, when the women had a hysterectomy and they didn't have to take the progestin, this medroxyprogesterone acetate, they continued that study. And that went for 8 years. But unfortunately, there was a crowd in the 60 to 90-year-old group that had an increased risk of blood clots. And so they stopped the study at that point.
Wow.
But, and so there's been many reanalysis of that. But I think what it comes down to, Sandy, and I think you are on board with me on this, don't put horse urine into your body, Don't put birth control pill type of progestin, in your body.
Yeah.
If you put back into your body the same thing that was meant to be there and you deliver it the right way, you don't have these risks of heart attack, stroke, and breast cancer. And, in 2012, there was a big British Medical Journal article looking at bioidentical estrogen, 17-beta estradiol, and they even had an unnatural progesterone. They used norethindrone. It's in Britain, so they use different progestins over there as they deal that way too. Those women had a 50% decreased risk of cardiovascular disease as they followed them. So it's about the type. So not all estrogen is the same. Not all progesterone is the same. Look at it like this. If you had two groups of people and you gave them both alcohol, one group, after a couple of drinks of alcohol were dancing around and felt great, and the others went blind and died. It's the differences in alcohol. One got ethanol, one got methanol. So not all alcohol is the same. Not all estrogen is the same. You want to put back into your body the same thing, not a similar thing. That's what makes the difference.
Yeah, that was such a great explanation, because I hear so many people who are like, whatever, I just went and got hormones, and they don't even know what they're putting in their bodies.
Right.
And I hear this regularly, and because I almost feel like it's a bit of a curse, Dr. Dorr, because I talk to too many physicians like yourself and experts, and I'm like, I know too much. I'm like, is it progestin or is it progesterone? There's a difference. Right. So
the women in the WHA that didn't get progesterone or progestin, they did great. And now when you look at them 20 years later, those women, even on horse urine estrogen, have a 30% persistent decreased risk of breast cancer.
Wow.
And they lived healthier. There was no increased risk of all-cause mortality or cardiovascular disease in that group. And now they're running a persistent decreased risk of breast cancer in the non-progestin group. It was the progestin in that study that was flawed and made the difference. So again, if you use progesterone, even with horse urine estrogen, you don't have those risks that go on. And all the lights come back on to your bone, to your brain, to your heart. And combined with testosterone, testosterone decreases the risk of breast cancer.
So, yeah, I like that you said all the lights come back on. Like, who doesn't want to age better and live with vitality until the day we're meant to end on this planet, right?
Right.
I'm with you.
What good is it living longer if you're not living healthy as you live longer? And that's what hormones do. They allow that, betterment of our brains, of our bones, of, those kind of things that go on. What good is it to live if you don't know that you're living, if you have dementia or Alzheimer's disease?
Yeah. So who are the people that are at risk? Who are the patients, or are there any patients that you have to handle very carefully?
Well, if somebody tells me, they take half a Benadryl and they pass out, okay, you don't have to prove to me that you're sensitive to medicines, and so you start out low and you work your way up. And that's great for any patient because you don't know what their right level is. So titration dosing, and the beauty of what we do at BioT is that there's a whole computer model that can kick out where 90% of people hit the right dose. And so that's the beauty of pelleted therapy and BioT. But you can do that with any drug that goes on. Certainly, people with history, you have to be careful in the delivery of hormones. So we weren't meant to take hormones orally. When you take hormones orally, it goes through your liver, it revs up stuff in your liver that increase binding or problems, but it increases blood clots. So when you take hormones through your skin or in a pelleted form, even a history of a blood clot or a blood clot to the lung or anything like that, it's not a contraindication to hormone therapy. So really, unless there is a condition like, say, breast cancer, there's certain types of brain cancers that are fed by estrogen, that's the only contraindication. So if there is a condition where a patient would be bettered by removing her ovaries, that's really the only contraindication to bioidentical hormone replacement therapy.
Okay. So what are your thoughts? And I don't know if you even do anything like this in your practice. It just kind of came to mind. You know how there's so many different things that you can take to redirect estrogens so that they actually metabolize down the healthy pathway, like DIM, diindolylmethane. Yeah. Then there's sulforaphane. I take sulforaphane. I've been taking sulforaphane for a long time. Because I also know my genetics. I have an aunt who died of uterine cancer and a great aunt who died of uterine cancer. And so I'm very cognizant of what's happening with my estrogens. Do you think that those are good solutions for women who are worried about how they're metabolizing those estrogens, or no?
Sure. So everybody that we put on hormone replacement, we put on DIM, sulforaphane,
Beautiful.
products.
Beautiful.
So, you don't know how people are genetically modeled with that phase 2 elimination of their hormones. And they can go down that beneficial antioxidant pathway of the 2-hydroxy versus the 4 or the 16-hydroxy. And that's where you're getting at with the Dutch testing, that you can actually look at that. But if you just put people on that, and I put all my men on that too, because same thing goes on with testosterone breakdown products and our estrogen that we break down as men. But yes, when you look at severity of, say, PMS symptoms, it's not estrogen or estradiol itself. It's the 2-hydroxyestrone that it breaks down into that gives women breast cysts and breast pain.
Yes.
And those kinds of negatives that go on. So if anybody that goes on birth control pills with me, I recommend, it tends to be, my younger crowd in general, so they don't want to do supplements and things like that necessarily. But I put everybody, on DIM. We have a combination product out of 2 different companies that helps with, especially if they're on artificial estrogens or progestins in a birth control pill. But in general, yes, everybody on hormones goes on DIM with us.
Yeah, it just kind of makes sure it's doing the right thing in your body. That's the way I like to describe it. It's making sure it's not going wonky on you and going in a direction you don't want it to go in. Okay. So my parents are both still alive. My dad is going to be 86 in April. My mom will be 77. And she's like, well, my mom never had hormones. We never had hormones. Why do we need hormones? What's the point? And I'm like, well, Mom, you can't say, first off, you didn't live as long back then, right?
Right.
And then
Right.
secondly, I think that life was simpler. And, like if you look at the way we live now, even cortisol can have an effect on all these other hormones. Like, what are your thoughts on this?
Well, when you look at our food supply, now versus say 1920 and an average bowl of spinach, it has a tenth of the dose of the nutritional content. So our farming, our soil, our things like that, things that we used to be able to replete our bodies with the precursors for hormones or things like that are not great in our food supply, is the deal that way too. Now, women have suffered with menopause for a long time, and there were preparations for menopause even in the late 1800s. There was pulverized cow ovaries that they used to give women.
Oh, wow.
Yeah, that was in the late 1800s. I think it was 1880 or something like that is when Overin is the name of it came out. But when you look initially at menopausal therapies, when the physician desk reference, so that is like this big compendium of drugs available, at least in America, came out in 1947, there were 53 different preparations from 23 different companies to help women with menopause. So menopause and symptoms of menopause and the nightmare symptoms that women had to live with have been around for a long period of time, especially as women started living longer, well into menopause is the deal. Certainly with the advent of modern obstetrics and getting women through the whole kind of nightmares that can happen obstetrically, women started living longer. So that's why we're seeing, women, aging and needing their hormones.
Mm-hmm. Yeah, I like that. I'm on board. Okay, let's shift gears and talk a little bit about the Women in Workplace survey. Talk to me a little bit. What is this? What was this survey all about? Give us the details.
Yeah, they took 1,000 women, aged 50 to 65. It was a study that came out through BioT in January. And they looked at them, ACOG is now saying there's 6,000 women a day entering menopause. That is a lot of people. And in fact, that is, from when I first went into practice in the early 1990s, that's roughly 3 to 4-fold more. But what they found was that many women are suffering in silence. That, 20% of people never, it's 20% of the workforce, but 87% of women never bring this up with physicians, let alone people in their workplace, and women are quitting their jobs. Mm-hmm. And that was brought up in the New York Times article too, that, women are leaving their jobs over how bad their symptoms are. They can't mentate, or they feel like everybody sees that they're having hot flushes in the workplace and they're embarrassed over bringing it up. And over half of the practicing OBGYNs are after the WHI that women stopped all their hormones, so they never got any hormone training. So nobody is helping all of these women, who are suffering silently, and they're leaving their jobs and they're not getting appropriate treatment or care, or they're going on other medicines that make them feel worse in many ways.
Wow. That, it's just, maybe I won't even say this, but what I will say, because I have to also be careful what I say, because I have a great relationship with my team of physicians. I have to have an endocrinologist because I have no thyroid and I had thyroid cancer. I have my GP. I have my naturopath doctor. And, it's interesting because I don't feel like I have the support I need with the way medicine is structured here. And it makes me sad, actually, when I think about this, because I'm fortunate that I'm in this industry. So
Yeah.
I advocate for myself. And, somebody put a little comment in something that I posted about, I posted a bit of a response to that article in the New York Times. And someone said, thank God for people like you because I have a full-time job. I don't have the time to research this. And so we're fortunate that we have a lot of women advocators now and physicians like yourself who take the time out of your busy practice to educate other women and their partners.
Right. Right. I thought this would just be a couple people a month as I looked at hormone replacement and certainly pelleted hormone replacement. And it grew to 50 and it grew to 100. And now it's like 600 people a month.
Wow.
That I'm seeing. There's such a need out there for this. And there's such a need of validating what people are feeling and the negative symptoms that they have, hormone loss in both women and men. And so, she brought up how women are suffering, but there are many men who suffer
Totally.
too.
Totally.
And their partners, women, suffer because their men are suffering. I see so many women who, I used to have a great sex life when my man was much more on board with everything. And so, sometimes women's dysfunction is their partners.
Oh,
So
yes.
it just led to many areas that I never saw my career going to.
Yeah, and here's the thing. I will always say lifestyle interventions help. They help. I do believe that there's a lot of things that you can take to minimize some of these symptoms,
Sure.
and there's no studies backed by it because there's no pharmaceutical company to back up the funding for the studies, right? So I can speak through firsthand experience. I take a lot of different herbs and they help me. And I am the N of one because I don't have the money to do a giant study, right? But
and that's what we really need is a groundswell of people for wellness rather than treating illness. So
yes.
we wait until people get their heart attack. We wait until people have Alzheimer's, which is too late. We wait till people have breast cancer. But could we put people on DIM? Could we put people on chasteberry or boron or black? Different things that help mitigate their symptoms and treat them to be well, or hormone replacement that treats them and helps them be well rather than letting them get ill and then treating them. That's the medical system.
Yeah. Backtracking is not an easy thing to do. So this is why I'm always like, get your lifestyle in order. Maybe take a few herbs that you feel help and then get optimized hormonally when you kind of set your baseline and go, okay, I've done everything I can do. I'm a healthy person. I'm going to go and see a physician like yourself and get myself some hormones. So
yes.
what is BioT? Talk to us about what that is and what is pellet therapy, because everyone talks about pellets in the US and I'm Canadian, so I don't know as much about it.
Right. So BioT is a company that was founded over 10 years ago, and they are a educational and promotional company. And yes, they do educate in many different areas, but pellets and pelleted therapy is their focus. And what pellets are, they're like a little grain of rice that goes through a tiny little 3 millimeter incision, usually in the upper bottom, but we can put it really anywhere that people have fat. Sometimes it goes in the abdomen or flank or things like that. But it's basically the same hormones as that's in a patch or a gel or a spray or a pill. It's the same stuff, like I talked about. Not all estrogen is the same. This is the same stuff that is meant to be in your body. And a pellet, when a pellet goes in, your body surrounds it with capillaries, and then every pump of your heart, in comes the hormone. It's like giving you a brand new 18-year-old ovary back. We just have to figure out how much you need. So that's the art to this, is how much of an ovary you need back, whether with the estrogen and testosterone coming back into your system. The pellet lasts for about 3 to 4 months at a time, so it's about 3 times a year, but you don't forget it when you go vacationing in Kona. You don't forget it on a certain day, or you have your patch on for 2 weeks and you've forgotten it. So it is less maintenance, and it's the same hormone delivered the exact same way. So that's why I see my patients, 90% of people that I see continue with that therapy. When I do other forms, it's only about 10 to 20%.
Okay. So if I can't do that though. I can't fly to you and get that done, can I? Just curious.
Well, yeah, BioT is getting close to 6,000 providers, more in America. We're seeing more and more Mexico rather than going Canadian so far, but they're expanding all over. And each year we're training a good 1,000 to 2,000 more. They just went public, and there's a lot of exciting stuff that's happening with the company now, starting in May. And so it's really getting the information about menopause, out there. And the beauty of pellets is that it's one of the most effective treatments as far as getting hormones in. It's just a matter of figuring out how much, that patient needs.
Okay. So I know this show is about menopause, but you treat men too. So andropause. So men can get pellets as well?
Yes, they can. When you look at shots, when you look at some of the other therapies, that's not bioidentical. It's modified testosterone. And that increases risk of blood clots or negatives that go on. Just like horse urine in women, there are these negative things that are pushed by pharmaceuticals because it's against federal law, at least in America, to patent and to profit off of what is native to the human body. So drug companies come in, they want a uniquely patentable substance which can't be native to the human body. So they modify it to be similar, but not the same. So that's why we like pelleted therapy, is because it's the same testosterone. And again, it's like giving a brand new testicle to that guy. It's the same stuff delivered the same way, just like in women.
Okay, so there is such a thing as bioidentical testosterone as well, right?
And then women, yes.
Okay. All right. Wow. Okay. I don't know if there's anything that we didn't cover. We kind of covered a lot.
That's a lot of stuff, Sandy.
I think so.
I have medical students and practitioners that can't follow me on a lot of that. So you were outstanding.
Oh, well, thank you. I do this every day. Okay, so let's summarize. Let's summarize what you can actually, by taking bioidentical hormone therapy at the right time and the right dose, it can help you age better. It can help to mitigate some of the risks as we age as women, such as heart disease, dementia, osteoporosis, and then there's the whole other, just the symptoms. Living with debilitating.
Quality of life is a big thing.
Yeah. I mean, we don't have to suffer, and I know some people will suffer for many years. So, yeah, let us know, where can we find you? It's a BioT. And if there's anything else you want to add and summarize, please do so, Dr. Dorr.
Yeah, BioT or BioT.com, BIOTE.com. And you can find a practitioner that's close to you in your area. We try and make this a very similar process. There are many different providers coming from different backgrounds. So there are people that are more functional medicine. There are people that are family medicine. There are people that are OBGYNs. So everybody comes about this from a little bit different angle. But the process and the pellets and the counseling should be somewhat similar in different areas. But, you try and find that person that you can click with. And there should be, like I said, there's providers in basically every state and almost 6,000 providers nationwide.
That's amazing. And are they in Europe yet?
I don't think so. I know Mexico and Canada, but I don't think they've expanded to Europe.
Okay, because they've
had pelleted therapy over in Europe, but I don't think not BioT yet.
Okay, wonderful. All right, thank you so much for your time. This has been such a pleasure. Maybe we're going to have to do a show on andropause.
I'm happy to do it. Like, I see 25% men now. We see probably the most men out of all the BioT practices. Is the deal. We're a big practice, for sure.
Oh, well, you know what? I've gotten a few requests, so maybe we'll have to do that. Okay. Thank you. Thank you so much for your time, Dr. Dorr.
Okay. Let me know how I can help, and it's been a sincere pleasure, Sandy. You're awesome.
Thank you. I hope you enjoyed this episode. be sure to share it with someone you know might benefit. And always remember, when you rate, review, subscribe, you help to support my content and help me to keep going and bringing these conversations to you each and every week. Join me next week for a new topic, new guest, new exciting conversations to help you live your best life.